So good afternoon, everyone, and welcome to the Oregon Bioethics and Humanities Colloquium presentation, Confronting Bias, Power, and Oppression in Pediatric Ethics. My name is Cliff Coleman. I'm with the OHSU Center for Ethics in Healthcare, and I co-chair this series along with Dave Hoyt, who's on the call with us today. Today's talk continues our 2025-2026 Oregon Bioethics and Humanities Colloquium, or OBHC, as we call it. And OBHC is a 7-part endowed speaker series that tackles complex issues and critical questions in bioethics and the medical humanities. I'm really delighted to introduce our 2 presenters today. Sarah Porter, MSW, is a social worker with Legacy Health Systems here in Portland, Oregon. And her practice is concentrated in healthcare settings, specifically with integrated behavioral healthcare, pediatric hematology oncology, including sickle cell anemia, palliative care, and social work and pediatric clinical bioethics. She's worked in a variety of integrated health settings, including home-based hospice care, inpatient acute care, and outpatient clinic-based care. She's an active senior member of Legacy's Pediatric Clinical Ethics Consultation Service as well. Dr. Dawn Hood Patterson, PhD, is trained in theology and began her career in spiritual care and chaplaincy. Straddling the landscape between theology and ethics, she has an interest in the impact of spiritual identity on medical and illness narratives. Dr. Hood Patterson is a clinical ethicist at Children's Health in Dallas, Texas, where her professional obligations include ethical consultation and institutional ethics. I'm delighted to have you both here. Welcome, and I'll hand it over to you, Sarah.
Thank you. Well, happy Friday, everyone. Thanks for taking your lunch hour to join us. Dawn and I are going to talk today about a tool that we've created and some work we've done that really kind of get at and require us to confront how bias, power, and oppression live in pediatric ethics, and specifically in pediatric ethics consultation. So we're going to talk today. So we have no disclosures, either of us, or conflicts of interest related to this work that we've done. And there are some learning objectives. We are going to talk about how we analyze power and oppression, and when we encounter social difference in clinical practice. We're going to talk about it in terms of pediatric ethics, but I think the concepts in a lot of ways are very applicable to kind of overall clinical practice in a variety of settings. We're going to show you a new clinical ethics tool that I created that specifically draws attention to how bias, power, and oppression exist in the ethics consultation process. And again, not a hard leap to extrapolate how those things live in regular clinical encounters. And then we're kind of going to evaluate the applicability of the new tool that I created. And Dawn's going to share a lot of really important information about work that she's done down there at Children's Health. So for a little bit of context, you heard our introductions and our bios, but I am Sarah Porter. I use she, her pronouns. And I'm a social worker by training with a long history in pediatrics. Pediatric hematology oncology was my main practice area, which of course is full of ethical challenges and dilemmas. And I worked on a really incredible team that did great work in that. I am now a manager of social work for Legacy Health, so do some leadership things. But I joined our pediatric ethics consultation service for Legacy Health back in 2014 and have done ethics consults during that time. And now I'm one of 2 folks who do our pediatric, adolescent, and maternal fetal consults for the Legacy Health system. And I love that work. And I love to think and talk about ethics. I chose to kind of further some of my education on the topic and participated in Children's Mercy out of Kansas City has a pediatric bioethics certificate program. It's the only certificate program for pediatric bioethics in the country. And I participated in that program in 2023, 2024. Through that program, we were encouraged to kind of engage in what they called a capstone project, which is our opportunity to create a project that was really kind of specific to our interests and needs. And through that project, I created the tool that I'm going to share today. And again, I'll talk about why, but it was a really fun project to kind of get all these thoughts I had had in my head for a long time down on paper. And through that program is also how I met Dawn.
Good afternoon. I think I'm in the right time zone. I'm in the central time zone, so I'm a little ahead of you all. But I wanted to just say thank you to Sarah for including me in this presentation and then also in this thought process as she's developed this tool. I do apologize, I have a cold and so my voice is a little scratchy, but I wanted to let you all know a little bit about myself and then kind of how I came into this work and into this project. So I have a background in healthcare in pediatric chaplaincy primarily, though I have worked a little bit in public health contexts related to adverse childhood experiences. I've also done some work with adults. I'm currently a clinical ethicist at Children's Health in Dallas, Texas. I'll talk a little bit more about my context specifically a little bit later in the presentation in the program. But the way I came to this work was I was new in my position at Children's Health, and there was a need or desire within the institution to screen for social determinants and drivers of health within the institution itself. And along those same lines, our ethics consultation service was looking for a way to also better evaluate and incorporate social determinants of health evaluation into our ethics consultation model. And so I took it upon myself to start to think about what this could look like, how this might manifest, what tools or resources we might need to make that happen within our consultation service. At the same time, Sarah was going through the Children's Mercy Pediatric Ethics certificate program, and I was involved as a content expert related to qualitative research. But I happened to sit in on Sarah's presentation related to this tool, and it just checked so many of the boxes that I was hoping to check. It was helping me to start to think about what I did in my mind and what I did kind of intuitively a bit in my practice, just because of some of my background and training. It really spelled it out in ways that I thought were really significant and meaningful. And so we'll talk a little bit more about my contribution after a little bit.
Thanks, Dawn. So as we laid out, I think both Dawn and I have kind of come to this work being very aware of how what we call social determinants of health kind of show up in healthcare. And I think healthcare over the time that I've been in it in the last 22 years or so has really gained a new appreciation for the impacts of people's social situation and environmental situation and how that impacts their health. And interestingly, I think ethicists and those that work in ethics have known that for a very long time. I'll make some arguments that they hadn't quite caught up to incorporating those factors into the ethics kind of thinking and process. But what we're sharing here is ASBH, that's the American Societies for Bioethics and Humanities, just published their 3rd edition of their core competencies for healthcare ethics consultations. And so this is a document that is largely kind of, I don't know if it's fair to say, Don, largely focused on adult ethics work, but they do try to incorporate pediatrics as well. But in this 3rd edition, they did recognize that a piece of core knowledge for ethics consultants and those that kind of actually engage in ethics practice is to be aware of the ethical issues related to social determinants of health. And so I feel like we're kind of finally starting to see the ethics field kind of catch up with what we've known for a long time. And certainly myself in social work and Dawn in theology have been very aware of for a long time. ASBH kind of defines the need to be aware of how social determinants of health show up in ethical issues And they give a long list of examples of things that they're describing as related to social determinants of health. And that includes unconscious and conscious bias, historically disadvantaged groups, the legacy of abuse of specific populations by healthcare systems. So really attending to some of those historical harms that continue to inform populations' experience with the healthcare system. They also call out things like racism, ableism, sexism, and heteronormativity. They call attention to the special issues that healthcare experiences when caring for unhoused patients, access issues in rural health, stigmatization that continues, particularly around folks they call it with substance use disorder and HIV. And then other populations that are made vulnerable in multiple ways, including unrepresented patients, incarcerated patients, undocumented patients, and marginalized patients. So this is the kind of, I mean, we included this to kind of show the expansive thinking that ASBH is using when they're talking about the social determinants of health. And to that end, right, if you work in healthcare in this day and age, you probably talk or at least hear a lot about SDOH, right, which is social determinants of health. We wanted to take a moment just to kind of speak to some of the languaging there, because as we showed, you know, ASBH takes a really expansive look at all the things that influence, that they kind of drive into the social determinants. And in fact, you know, we have identified, as Dawn and myself, and we had a couple other partners in this work too, as we've identified, we have a little bit of, there's some language confusion going on. And when we talk about SDOH and the original language of social determinants of health really speaks to kind of structural and institutional factors that impact people's health, right? That might be access to food in the neighborhood that you live in. That might be access to green spaces with lots of trees that provide shelter and cool down hot days. That also relates to kind of access to education and the quality of that education, economic stability, many factors that are outside of the control of the individuals that we're taking care of in healthcare. Now, you know, what we see often in healthcare at the individual level, at the clinical care level, are the social drivers of health. And that looks like this is the SDOH wheel from Epic in the middle here, this picture in the middle, which really speaks to health behaviors that drive people's health, right? And those health behaviors are often created from, in part, or influenced by the structural determinants that exist for folks, but we're seeing them a little bit more on the behavioral level or the like direct individual impact level, and those we call drivers. And then there is this concept that we know I haven't heard us talk as much about the social dynamics of health, right? And that is how, and I think ASBH is actually speaking to some of these when they're thinking about how historical experiences with the healthcare system continue to impact the dynamics that we experience when we're caring for folks. And so while the dynamics impact the drivers and the determinants are impacting all of it, it's really also can be looked at as a really kind of cyclical conversation between these factors that are at play. Dawn, I don't know if you want to say anything else about these. Okay. So we just wanted to lay the stage. Again, I'm a big supporter of expansive thinking when we think about things. And so this is a nice slide to just kind of help us think more significantly about what SDOH means and how SDOH comes into clinical encounters. Because it's often in the dynamics and the drivers where we experience this phenomenon the most when we're working individually with people. Okay, so now I'm going to kind of take some time to help us to tell you all about the tool I created. So I call it the POTM P. Spent a long time trying to think of something clever. I didn't find it. So this is what it is. And it's a novel tool to engage in clinical ethics consultation, specifically to pediatrics. But like I said, I don't think the extrapolation to adult ethics work or even to clinical practice is that challenging once we look at it. So as I had said, I did this as a capstone project, and the minute I heard I got to do this, was invited to engage in this project work, I instantly knew that that I wanted to do something to confront the absence of attention to things like power, bias, oppression, and these social dynamics that exist in the process of clinical ethics consultation. I'm a social worker. I feel like social work talks about these things and how they are present and how they are present in the actual work that we do with individuals. It's a fundamental part of social work school to talk about power and oppression and how we mitigate that and how we work through that in the work that we do with folks. And I was kind of really disturbed, maybe is a little bit strong of a word, but definitely kind of bothered by the fact that clinical ethics, however one goes about engaging in clinical ethics consultation, I didn't think there was enough attention to how bias, power, and oppression are present in the process of engaging in clinical ethics consultation. I think for a lot that do clinical ethics, we feel like we are neutral third parties. I hear that a lot. We're neutral third parties that come into these clinical encounters. And I'm not insinuating that that's incorrect, but interestingly, we're still, I felt like we had failed to recognize that we're still a member of the healthcare establishment, that we still speak the language of healthcare, that we still understand how to navigate a healthcare system. And that positions us in a certain way with the people that we're serving. And I've done, many of the consults that I have done in pediatrics, adolescent, and maternal fetal medicine have really involved things like power dynamics, really significant bias. And I also was kind of I think sometimes in ethics we talk about the cases that haunt us, and I was really haunted by some cases where my recommendations as a consultant were really oppressive and ended up creating situations that were experienced as oppression for the people in that consultation process. And and I think that that's probably true for lots of folks that make recommendations in healthcare, is that there's often an edge of power or an element of power and privilege that goes into those recommendations that can create that experience. I also wanted to address some challenges that we have specifically in pediatric ethics around the best interest standards. And my best description of that challenge is that if you've, and this can happen in adults too, for sure, but if you've worked with children and families, we often have conflict where the medical team can look at me as an ethics consultant and say, this is in the best interest of this child. Absolutely, this is in the best interest of this child. And I'm like, yeah, I see that, right? You're making really strong, empirically informed medical recommendations that are taking into account all the individual factors of this child's medical situation and concerns. And yes, you are producing recommendations that are in the best interest of the child. I see that. And then I talk to a family, and that family is like, this is in the best interest of this child. And it's not what the medical team's recommending. Sometimes it's the direct opposite, or sometimes it's a variation of that doesn't feel comfortable for a medical team. And I listen to them explain to me why that's in the best interest of the child. And I think to myself, yes, that is in the best interest of that child. And then here we are, we're locked in a situation where the term best interest that's trying to guide our work means two different things, and both things are true. And that is just representative of the complexity of healthcare in this case. In this day and age, there's very few single truths anymore in this work. And it's always, I was stuck because the medical team was like, well, we have to do what's in their best interest. And I was like, well, all you're saying from my assessment is that we can do one of two things, right? Which doesn't, or that, I mean, even that's a binary that rarely exists. We're probably talking about one of five things, but it doesn't, that alone does not help us understand how to kind of get to a decision point in any of that. A couple other things to think about. So on the slide here, you're seeing on the right-hand side is this is the 4-box method of kind of organizing information and thinking about information from clinical ethics. It's from Johnson, Siegler, and Winslade, and they have kind of refined it over the years. And it's a really helpful tool. It's a tool my institution's used to kind of help us organize information and make sure that we're getting to all the things, right? Like as we're doing a consultation, are we attending to the medical indications? Are we attending to patient preferences, which we often describe as they can often be parental preferences or parental authority when we talk in pediatrics. sometimes patient preferences though. Or have we looked at quality of life? Have we thought about it? And then there's this large box that's in the bottom right-hand corner of the 4 that speaks to contextual features. And I feel like that is everything else. That is all the social determinants of health. It's all the social drivers of health. It's all the social dynamics that are playing out in the clinical care experiences. It also includes all the things that are around justice and fairness and access. It's a really big box. It's huge. And I don't appreciate that some of these social dynamics and some of these elements of power and bias are kind of, I feel like, relegated to that far corner where they influence stuff, but they almost can be kind of seen as outside of what's really important. Because a lot of times we can zero in on those medical indications and those patient preferences. And sometimes I feel like it's great to spend time thinking about contextual features, but relegating all these social dynamics to that space doesn't attend to them to the same degree to which I feel they're strongly involved in the consultation process. And additionally, I haven't found tools that had guide the consult process or had centered the patient narrative or story in really important ways. So I created a tool. The key components, you're going to see it on the next slide, is that it's a behavioral tool. I actually guide what I want consultants to stop and think about in that consultation process. So it's behavioral. It's not just kind of a thought game or experience for people. It's actually meant to be behavioral, to follow along. It's meant to honor those social dynamics that are present in all of these clinical interactions. It attends to power as a relational dynamic that needs to be considered. And I also really tried to turn theory into action. So it's heavily informed by the reasonable interest framework, which Micah Hester and Erica Salter published in 2022, and I'll explain why. And then there's another great article from some folks up at University of Washington who looked at how to address racism in ethics consultation, and they kind of built out an expanded 4-box model that factored in racism in some important ways. So this is the tool I created. It reads from top to bottom, left to right. All the blue sections are behavioral-based reflections that I'm encouraging a consultant to engage in. The green section is speaks to the process of gathering information in a consultation process, with the goal also of making sure we elicit narrative. And then the purple section, which is between the bottom, sorry, I live with someone who's colorblind, so I recognize that people don't always see the colors. So the purple section is kind of near the bottom, one up from the very bottom, and it's an analysis and decision-making section. And this is where I tried to bring in pediatric specific considerations into that process. So to build on more about these blue sections, so the top reflection is where we start in an ethics consultation process. And again, if you don't do ethics consultations, but you want to extrapolate into clinical care, I think you'll see a lot of parallels. We start with what is this ethical question is asked? And then I really use this section to attend to power. So in addition to hearing what this question is that we're being asked, we also need to identify the stakeholders. And instead of just identifying the stakeholders, I actually want people to think about whose voice has been heard and whose voice has not been heard, right? So often I get these consult requests and I hear a whole lot from the requester, right? Which might be a physician, might be a bedside nurse, might be a different member of that care team. But I need to ask myself, whose voice have I not heard? Have I not heard the attending physician's voice? I'll say often, I haven't heard bedside nursing's voice. That's a voice I really need to hear. And then I have to ask myself, who in this patient and family sphere, in their little system, whose voice do I need to hear and do I not? If this consult's for a neonate or an infant, I don't need to hear that infant's voice. I can hear they're crying, but they probably can't tell me anything. The consult's for a 17-year-old, that's a voice I need to hear, or a 12-year-old, or whatever that is. So it's actually asking you to think about stakeholders through whose voice is missing and whose do we still need to hear, and to very quickly survey that landscape and say what power dynamics are present at this point. So the second reflection that would happen after we've gathered information, and I'm going to talk about gathering information is really about pausing for bias, right? So we've identified our stakeholders, we've heard the voices that we feel like we need to hear, we've gathered some information. Now we need to pause and say what biases are coming up for me in this consultation process. And in the consultation process, but also for me as a consultant, right? And this is where I can model for teams to say, like, what biases am I experiencing? What am I feeling? And how do I call attention to those so that they can kindly exit the consultation process, or at least be attended to in that process. And then in this kind of thinking about bias is also thinking about how the social position of the consultant themselves are influencing the consultation process, right? Like I show up, I have a social position that I'm bringing to the consultations I do. You know, I'm well educated, I've worked in healthcare a long time, I speak the language, I'm white, I'm female presenting. How are those things impacting this experience? And then the final reflection really attends to oppression. And it attends us and asks us to think about what power differentials or how are our recommendations that we're making contributing to power differentials and potentially creating oppression. And Dawn's going to kind of build this out more for us. And then how can we factor in some mitigation of that power and oppression? I will be the first person to tell you we cannot make power disappear from clinical encounters in healthcare. It doesn't work. But how do we mitigate that? How do we think thoughtfully about how to make our recommendations and our final choice of action be one that mitigates power and oppression to the degree that it can? And then throughout this, I've kind of worked to center cultural factors to really kind of build up that narrative for that patient and family. So the two other components of this tool were the green section of assessing and organizing information. Some key points here are really about who gets to determine what, who gets to speak to what, because I've had many a medical team say, well, this quality of life is, and is, you know, they rarely say not worth living, but it's like this quality of life is going to be really bad, or this quality of life is really pretty good, or, you know, and so I hear a lot of kind of medical team judgments about quality of life, but there's lots of reasons and research that support the fact that medical teams tend to underestimate perceptions of quality of life than parents do, particularly for kids with significant medical comorbidities. And so this box really builds on that reasonable interest framework to say who gets to define what. So the circle on the left is the clinical team circle, and they get to define medical beneficence. They get to define what is medically beneficial in this case. They also get to help us understand any reasonable alternatives that might exist to courses of action. And then the circle on the right-hand side is the patient and family circle, and they get to tell us about quality of life. They also get to help us define the best interests in terms of their child and in their cultural context, while also stating their preferences and helping us understand how relevant cultural factors might be playing into this. So this was really important, and I have blue arrows there to say the medical team gets to determine medical beneficence, and the family and that patient get to determine quality of life for us. And then this purple section is really pediatric specific considerations. So, you know, it's meant to be a little bit of a grid that one can follow along, identifying that we need to clarify that ethical question and identify that if we have agreement, let's move forward. Now, when we don't have agreement, we either need to apply some ethical decision-making frameworks, such as the zone of parental discretion, such as kind of considerations of when we should constrain parental authority, and also thinking about how uncertainty might mean that we need to weigh a patient and family's preferences more heavily because there's some medical uncertainty. It also calls out, and I also wanted to do some work trying to interrupt automatic child welfare reporting or knee-jerk child welfare reporting, which is a problem I see in pediatric healthcare. I wanted to interrupt that by saying that when there is not agreement and there are concerns for imminent or significant harm in the context of clear benefit. So those situations we may say we need to engage authorities. I actually want us to utilize something called the harm principle, which Don will talk more about, but it's ultimately a tool published by a pediatric ethicist that asks 8 questions to kind of have us test whether child welfare reporting may be indicated, particularly around situations of medical neglect, and consider reasonable alternatives. So sometimes we in healthcare like to think that we know the one right way forward, and the reality is there can be many a reasonable alternative that's also worth consideration. So that is the tool in its entirety. And now I'm going to turn it over to Dawn and let Dawn tell us a lot more about some theory and how they've applied this at Children's Health.
Thanks so much. I want to start just by giving a little bit of background about where we are, where I am, and where I work as a clinical ethicist. We're a tertiary standalone pediatric hospital. We have 2 campuses. We have kind of a central campus near our downtown area, and then we also have one that's kind of north of the city. We are standalone, but we have an academic affiliation with UT Southwestern. They house the physicians, the advanced care practitioners, and they also have the medical school. But people who are training in pediatrics will do their training at Children's Health. So we have a really close relationship with UT Southwestern, which is a state entity. We have 10 ethics consultants on our team. We have 3 who do this full-time, who do ethics consultation full-time, one of which is our program director who has some administrative duties and obligations. And then I work with another clinical ethicist named Stephen Couch in the program as well. We also have 7 consultants who have clinical or administrative responsibilities. They range from someone who's a leader in social work, the social work department. We also have a nurse, and we have physicians from the NICU, the neonatologists, the pediatric intensive care physicians. We also have a pulmonologist on our team. And we have an emergency room physician who all contribute their time and participate in consultations with us. We usually take a dyad model. So when we have a consultation that is a little more rigorous or that is prolonged, we will partner amongst ourselves to ensure that we have extra sets of ears and eyes. And this happens when we can. Sometimes we have limits on our time and our abilities, but that's generally the model that we take with consultation approaches. When I heard about Sarah's tool, I was really excited, and I thought this is certainly transferable. This is something that our consultation team could learn to use and could implement in a way that kind of formalizes or concretizes the consultation process. Everybody on our consultation service, and this is still going to be true, everybody brings their own flavor, their own kind of set of lenses, but what we wanted was a way of streamlining consultation so that we weren't missing big pieces of information in our consultation approach. And so we set this in the framework of an SBAR, situation, background, analysis, and recommendation. And we do that simply because that's how we're familiar with reading information in our institution. And so I translated it a little bit. By translating, I put some boxes where Sarah didn't have boxes. We did some training initially with the ethics committee, and that was really some foundational information related to social determinants of health and how to start to evaluate power and oppression within clinical contexts. Our ethics committee is really a committee that is committed to ensuring that our consultation service has extra ears and eyes, but they also do a lot of policy work and institutional ethics work. I also began training our consultation service, the members of the consultation team, those 10 people. And I'm going to get my water close because I have a cold. But we began doing some training around this tool that Sarah implemented. And if we want to advance to the next slide, I'll start to show what some of this looks like. One of the things that I identified early on in my work at Children's Health was this reality that our consultation service was actually really committed to paying attention to situations where power dynamics were at play. And we had kind of a collective sense that power dynamics were always at play. And we needed to be able to assess these and make meaning out of them and think about them perhaps in a more objective light. And so I wanted to equip our consultation service with a way of thinking about when we come across this situation of evaluating power, how do we do that? What tools do we have at our hand to do that? So I really started to teach our consultation team about the 5 phases of oppression and the forms of capital from Bertot. And I'm just going to briefly show you one of these training sessions that I put together. This is the one related to the 5 phases of oppression. I built out different slides related to the 5 different phases of oppression: exploitation, marginalization, powerlessness, cultural imperialism, and violence. And on the next slide, you'll see an example of this kind of more manifest. This is an example of marginalization. So we talk about the definition. We talk about what does it mean whenever we experience ourselves or when we see in a clinical context marginalization. And I put a few examples of how this might show up in pediatric healthcare. And this information is available for our ethics consultation service or consultants to use as they think through a certain case or ethical dilemma. We did a training related to like having them work through a case and think critically about the power dynamics within that case, equipped with Bertot's forms of capital, and then also with the 5 phases of oppression. Following, thanks, Sarah, this slide is just to point out that we really translated this exactly in our model. Sarah did such a great job of kind of highlighting. Go ahead and, yeah, the next slide is great.
Sorry, I'm having like quick fingers.
Oh, you're fine. This is totally fine. Sarah did such a great job of highlighting the way in which there are certain criteria or obligations of the patient and family, and also certain obligations for the clinical team. And so I point them back to this article that Sarah used to develop that part of the tool and help them think critically about where the clinical team may not be standing up for or standing up to their obligation, to think critically about different options available and the different medical beneficence that's at play, and then also to like help the consultation team to think about where the family has not yet clearly defined or may need help in defining what the quality of life is. And then also helps us kind of think about role creep or encroachment. So whenever we have the clinical team talk about the quality of life of a patient, we can kind of say, well, let's kind of think about your role and obligation in this. And also whenever we have patient and patient families who talk about, I saw on TikTok or I saw on Instagram, we kind of start to think about with them, what is their obligation as far as like paying attention to what is medically possible for them. And so it helps us to define roles in a way that gives us fluency in talking about that. In this article, I have one small bone to pick with the authors. They talk about epistemic equality, but they don't actually define epistemology. And so when we're talking about retaining epistemic equality, I really wanted our consultant team to think about what are the implications of epistemology? How do we actually come to the knowledge that we have? And how is that informed by different life experience, different education, different lenses that we carry through our world? And so I have a teaching on epistemology. I think it's a really fun teaching because it's asking people to evaluate how they know a color is vibrant. And it's based on this reality that people may define vibrancy of color in many different ways. Some of it is a very scientific way, some of it's more of an artistic way, some of it is just because it makes them feel a certain way. And so it's a way of pointing out epistemology, and then it helps them to think critically about how epistemology informs the way that they bring knowledge into the clinical setting. And then it helps us understand a little bit better about when we ask you to regard others with epistemic equality. We are asking you to do something pretty specific and distinct. And so that's the trajectory of that part of the training. If you want to move on. In this section right here, this is where we turn to the reflection section. And so I've put together a few ways of thinking about how to move through this reflection. For the first bias pause, I provide them with information about standpoint theory and perspective taking. We also do training on Johari's window to kind of give a sense of like, what are sense of what is known and unknown about our own lived experience and our own potential biases that we're bringing to the situation. For the second, what still needs to be known or understood, we talk a lot about social drivers or determinants of health, and that's where I ask them to go specifically to the social determinants of health screening that our hospital system does for patients, and look at that and start to get a sense of like, what are some potential barriers that this family may be facing in carrying out the healthcare plan for their child. I also ask them to turn back to that expanded 4-box method that Sarah talked about. I point them directly to that. I specifically keep that tacked to my wall in my office. And after I meet a family, I go back to that literature. I look specifically at the questions within the expanded 4-box method, and I start to jot down things that I still do not know or I think are relevant or important to know in evaluating this case. And then finally, I ask them to start to think about understanding privilege and how privilege might have an impact. And with that privilege, also to understand the ways in which marginalization might also show up in their own experience. And we also do an ID, we evaluate values, identification of values. So here's just some examples of some of the trainings that we've used to kind of build out that section of reflection. I'm going to give you a second to pause on that standpoint theory cartoon. I really like it. There's a joke in there, but you'll have the slides after, I hope. But it's just an example of some of the trainings that we use for that section. And if you want to move to the next slide, please. For this one, we just recreated it. We recreated it because it is a really helpful flow chart for us to think about some of the pediatric decision-making frameworks. And so I'll show you what it looks like on the next slide. Oh no, I didn't. Sorry, I cut that slide. I'm so sorry. We just recreated it. But these are the two articles that we have linked to that flow chart in our tool at Children's Health. It's the zone of parental discretion and the harm principle. These are two really helpful and important tools that we use frequently in pediatric ethics. The harm principle I find really helpful, particularly to avoid those, as Sarah described, the knee-jerk reaction calls to Child Protective Services. One of the things that the author does that I have used repeatedly is he provides an 8-question chart for people to kind of critically think through if it's appropriate to supersede or override parental authority in different situations based on the potential for harm and the potential for harm in like the immediacy or near future. And so what I do often is I bring those questions with me to a care team meeting where we're meeting as different interdisciplinary members of the care team. And I have the team walk through those questions individually and discuss among themselves how they would want to answer that question. And it is remarkable to me how there is then a shared knowledge and consensus as to why we are going to proceed and call CPS or why we may not decide to call CPS. And so there's a shared collective reasoning that happens whenever we actually take out these questions and deliberate as a group. On the next slide, we're going to move to that last box of reflection, and some of the tools that we put together as we start to think about how do we mitigate power dynamics within the final reflection. And then in that last box, you probably saw that you ultimately culminate in some recommendations. And that's what we do as well. After all of our evaluation, all of our fact finding, we like to bring some concrete recommendations. These are the two articles that I point our consultation team to in thinking through recommendations. They may be specific to my context and some of the needs that our clinical team needs in my particular context, but I do think that they're very helpful in many different contexts. This idea of titrating clinical directiveness in serious pediatric illness is a tool that I turn to very frequently. The authors identify 6 different domains to evaluate when thinking about how directive should they be with a family and providing recommendations. And it goes from very low to moderate to high to near complete directiveness. And so this is a really helpful article and tool that I bring out and I teach on in different occasions, but I also help teams start to evaluate the different criteria or considerations that they should be walking through or thinking through when they're getting to a point where they think, okay, this family may benefit from a more directive approach, or it may be inappropriate to be super directive in this circumstance or this situation. So it's a way of kind of making more objective this approach to clinical directiveness, so that you're not using a bazooka when a scalpel would be appropriate, or vice versa. And the reason I list this informed non-dissent article here, there are many approaches to informed non-dissent, but I think that in this particular article, Dominique Wilkinson and co-authors, they lay out a pretty helpful, this is some language that you can use, and these are kind of the steps that you should take to kind of make clear, where are we with your child? These are some of the circumstances and conditions that have brought us to this. Do you understand? Offer moments for reflection, pause to see if there's any steadfast, absolutely not, and this is why situation, and then inform the family about how to proceed, or how the care team plans to proceed from that point. I just think it's a really helpful way of just making concrete something that can sometimes feel a little bit ethereal when put into practice. So those are tools that we give them as they start to move toward recommendations. And what we wanted to do today, and these are some citations that we have just in building the tool, and then also kind of bringing the tool to life in ways that train our clinical staff at Children's Health. What we wanted to do is not only show a tool that is just, I find it really helpful to think through, critically engage an ethics consultation process, but then also some of the theories or additional tools that help bolster moving through that tool in a way that is that makes sense, or that engages you in a critical thinking way about this tool. We want to have time for questions and conversation, and so I'm going to pause there.
Thank you so much for just a really amazing presentation. I'm so intrigued, and there's so much to digest here. I've offered to, or invited attendees to include questions or comments in the chat, and while we're waiting for folks to digest the material and formulate their comments and their questions, I'm just very struck by I think the many layers and of impact I can see with the tool like this. And right off the bat, what I'm thinking is, we work in a world with so many systemically baked in inequities that, and it's oftentimes we kind of forget that we require systemic approaches to systemic inequities, right? So like a tool like this is a way to do that, right? Like when we have all our blind spots and we do go about our day-to-day work, and it continues to produce the same inequitable outcomes that it has for generations, how do we break into that? And I think developing and implementing a tool like this is a great way to raise that, to open people's eyes. Um, so I really thank you for that.
Yeah, I'm a big believer that if we don't recognize or we don't take some time to be aware, then we can't work on any of it. So, part of it was just about saying like, hey, we need to get comfortable talking about how these things exist and how we contribute to them, and then we can start doing some work around that.
And that's actually, I think, speaking to your point specifically, that's one of the reasons why I really wanted to include some self reflective practices. Sarah built that into the tool. She asks people to pause and be self reflective. And one of the tools to do that is that Johari window to start to identify what is known to me, what is unknown to me, what is known to others, but not to me, and what is known to everybody. And so those tools help us kind of to take seriously the pauses that Sarah has asked us to do in our consultation practice, because absolutely we have blind spots.
Yeah, yeah, I love that. I wonder if you all have a sense of how general the use of the Johnson model is across, sort of across settings. And it strikes me, it seems to me that it's, if anyone's using a model, that's what they're using.
Mhm.
And then maybe there are places that aren't using a model or not. I don't know that, but and then I'm picturing how I mean, I love that you essentially just said the contextual features box needs to get sort of blown out,
Yeah.
and some specificity built into it. Because without that, whatever blind spots we bring, we're going to just fill in that box, uh, as we live our lives and as we think and carry all those biases that we all carry. So I'm just curious if you could comment on maybe the tension between having that older four box model that people may be very familiar with versus this much more robust but also very different looking model, and how the world might be able to grapple with those two distinct models.
Yeah, I mean, it's very well known, and it's an interesting model because it's really good for collecting information. I do think it does a nice job of holding us accountable to collect a robust amount of information that doesn't just focus on the medical indications, doesn't just focus on quality of life. It actually asks us to think about that, and so I think that's where its primary utility has come from. It it has always stopped short of telling us what to recommend or what to weigh more heavily. um that's not, it can't really do that. It really is about data collection. And so, in some ways I don't necessarily view the tools as competing, because it is really about collecting information, and it has good questions about getting at what are the medical indications that matter in this situation, and what, how do we think about quality of life. I mean, I think because it's not a process tool in my experience, right? It's data collection. Um, it falls short in those process spaces where I think this tool has tried to get at process and tried to, center things. I mean, that's the hard part about that contextual features is those are huge for the families that we work with and the patients that we work with. And they're big. They're big in the consult process, and yet they're not centered in a way kind of in that four box model. So, it has been around forever. I think it's really, I mean, if people don't use, I mean, I think probably almost everyone uses some element of it just in terms of thinking through like what information do I need for this case. But yeah, they're definitely non competing in my mind. Although I do hope people embrace a little bit more of the practice. The thing about the reflection too was really about, how do um how do we build muscle memory for remembering to think about these things? And I think, a list of questions people should challenge themselves with are useful. And I don't know that they really build that kind of muscle memory around like Who have I not heard from? What biases are coming up? And so that was part of the process. I see we have
There's a comment in the chat.
Yeah.
Andrew asked, can you give specific examples on how consideration of SDOH has impacted specific recommendations in clinical consultations?
Dawn, do you want to go ahead?
I can do one briefly. I had a recent consult where this mother was really concerned about the mechanism by which her child could receive food. G-tube, NG-tube, by mouth. And she had pretty clear notions about certain things that she wanted for her child and certain things she did not want for her child. And in looking through the chart, it became really clear to me, both at looking at her social determinants of health screening, that she lived with substantial financial and food insecurity and had a really high risk for those insecurities. So it led me into a place of deep curiosity as to what was the relationship between her determination about how her child would receive food and her own sense of insecurity about food. And I don't know that without kind of paying attention in a really specific and called for way through using Sarah's tool and using the social determinants of health screening, that I would have been as curious about it as quickly. I may have gotten there. I hope that I'm a curious enough person that I would have eventuated into that spot. But having that those triggers to think about what are the outside or external factors within this family's context that might have a bearing upon decisions for this child, that came specifically through some of this reflection on social determinants and drivers of health.
And I think we have time. And you know, Dr. Lasky asked this question, and he knows me well and my consults well, as he's my partner in pediatric, adolescent, and maternal fetal consults for Legacy Health. But when we had a case where the medical team was strongly advocating for nursing home discharge for a child with peritoneal dialysis and a tracheostomy. And part of housing insecurity was a significant component of why that recommendation was being made. The challenge to the recommendation is that that facility was 4 hours away in a different state, because pediatric kind of nursing facilities in this part of the country are very hard to find. And really, it was very hard for the team to imagine a safe plan coming together with elements of housing insecurity. And so being able to really, through the consult process, attend and to understand how that housing security was impacting the consultation process, or the kind of the issues that were at play, and how the family was thinking about the role of housing insecurity and what they wanted, which was a discharge to home. And I think that was really important, because in some ways it was felt that the goal for discharge to home was unrealistic, and just not, you know, because of the housing insecurity. And yet that choice was based in other values that were exceedingly important to the family. And so in that case, I think attending to identifying and attending to the role of housing insecurity for this family was important, because it allowed us to also have those conversations and then understand the goals of that family through different value sets that helped us understand their motivation and why a discharge to home would be value aligned instead of kind of irresponsible due to SDOH factors.
Yeah, that's a great one. All right. Well, I want to thank you both so much for a really wonderful presentation. I know people are starting to drop off and heading to their next activities. Thank you all for attending today. And then I just want to announce that the next talk in our OBHC series will be on Friday, December 12th at noon. Dr. Alyssa Newman from the Kennedy Institute for Ethics or of Ethics at Georgetown University is going to be speaking to us on medical mistrust, conceptual insights, and empirical challenges. So thank you all so much. I appreciate you and have a great rest of your day.